Hello everyone, welcome to our webinar, Using Standing Orders to Boost Immunization Rates, by our presenter, Dr. L.J. Tan. Thank you for participating. Before Dr. Tan, the presenter, starts, I have a few items to review. All your phone lines are muted. Please use the chat function to ask questions or to send comments. At the end of the webinar, Dr. Tan will answer as many questions as time allows. Dr. Tan agreed to answer any remaining questions, which we will email to all of you. In case you lose the online viewing of the slides, please stay on the phone and follow the presentation by using the slide deck attached to the second reminder sent out yesterday. We are recording this webinar. We will email you the link when the recording is ready. Dr. L.J. Tan is Chief Strategy Officer for the Immunization Action Coalition, or IAC, which he joined in 2013. Previously, he was Director of Medicine and Public Health at the American Medical Association for 15 years. Dr. Tan is co-chair of the National Adult and Influenza Immunization Summit, a joint project with the IAC, the CDC, and the National Vaccine Program Office. He recently served on the National Quality Forum's Adult Immunization Expert Committee and is a member of the Pharmacy Quality Alliance's Adult Immunization Working Group and the European Society of Clinical Microbiology and Infectious Diseases Vaccine Study Group. He is also an editor of several professional journals. He just completed his term as an elected member of the Federal National Vaccine Advisory Committee, and he continues to serve on its HPV and Vaccine Confidence Working Groups. Dr. Tan was a liaison member of the CDC's Advisory Committee for Immunization Practices, or ACIP, for 12 years, and currently serves on its Adult Immunization Working Group. I'm now turning the presentation over to Dr. Tan. Thank you, Dr. Tan.
Great, thank you so much. And just want to make sure, can you all hear me?
I won't be able to answer you, Dr. Tan. They're muted.
Okay, but you are able to hear me. That's good. Thank you so much.
Yes,
okay.
Everybody's responding, yes.
Fantastic. All right, thank you so much for this opportunity to talk to you about something that's very important, but also something that we're beginning to kind of try to reinvigorate throughout the country through our Take a Stand program. So again, just to kind of mention that program because it is the basis for which this presentation kind of started. And this Take a Stand program actually is a national program where we are actually doing workshops across the country to try to implement, and implement is the word here, is to basically ensure and take a practice or system by the hand and get them to implement standing orders in their practice or in the system. And this Take a Stand initiative, we've done 23 workshops across the country. We've learned a lot, and hopefully we've also been able to share a lot. And I'm going to, and some of the things I'm going to talk about in today's presentation are actually things that came out of some of the things we learned from that workshop. But the purpose, again, was to implement standing orders in these healthcare systems and these physician-provider practices. And the disclaimer slide here is important because essentially what it says is that the content for all the workshops, as well as today's presentation, and anything else that's related to the Take a Stand program, while it was funded by Pfizer Vaccines, the content is independent of Pfizer Vaccines. They have no role in the creation of any of the content for today's presentation or for anything else that's related to Take a Stand. And since I will be sharing you a bunch of the resources that we developed as part of Take a Stand, as well as obviously today's presentation, I think it's important to emphasize to you again that the content is independent of the Pfizer funding. Great. So today, this is kind of what we're going to try to focus on. And excuse me if my voice kind of goes a little bit here and there. I'm fighting off a cold, and my throat's a little bit on the sore side. I apologize for that. What to talk about today is, kind of set the stage at a very kind of high level. What are standing orders, so that we all kind of have a sense of what they mean and what they are. We're all talking about the same thing. And then I'm going to go through and talk about the different components that should be part of a standing order. And this is important because I think what we'll show you later on is that these components are not prerequisite to any kind of standing order protocol, but they are things that we believe are best practices that should be in a typical standing order protocol. And then I'm going to go talk a little bit about the evidence, and there's quite a bit of it, that supports the use of standing orders to vaccination coverage rates. That should be vaccination coverage rates, not vaccination rates. Apologize for that. And then also talk quickly about how we perceive how standing orders can actually benefit medical provider practices. So, physician practices, independent practices, or practices within healthcare systems as well. So let's start with some rationale for why all of a sudden, standing orders aren't a new thing. I mean, we've been doing standing orders for a while. Our biggest challenge is that standing orders, and I'll show you this a little bit later on, are just not well implemented. And we do have a problem that prompts the use of standing orders, and the problem is the fact that our adult immunization rates are very, very low. Flu and influenza aside, which are not satisfying, we all know that obviously that the adult immunization coverage rates for hepatitis B vaccines, for Tdap vaccines, for zoster vaccines also remain troublingly low, and specific to populations with chronic illnesses who are at high risk for complications should they contract one of these adult vaccine preventable diseases, those populations at high risk are even poorer vaccinated, and so even more poorly vaccinated. And I think that's one of the reasons why we're starting to pay a lot more attention to adult vaccinations. And the challenge is that, what it is that these patients are not getting their vaccines when they visit physician or provider practices, and that's not, that's not surprising really when you consider the fact that our adult patients have transitioned from this era of good preventive care visits, which we had in our pediatric model, to a model now when they come through adolescence and young adulthood, where we're no longer actually valuing preventive care. And majority, in fact, I would almost say all of our visits to physicians' health for young adults or older adults tend to be, visits for maintenance of a chronic illness or for an acute care situation. And so because of that, it makes total sense that any clinician who's seeing an adult in front of them is likely seeing that adult to address either an acute or chronic medical condition. And by the time they deal with that issue, and when you couple that with the lack of evaluation for preventive health issues, vaccinations for these adults get left behind. And obviously, this is important because, you cannot vaccinate if you've not assessed the patient. And that's what's happening. We're not, the first step to assess that patient is not happening because of all the competing priorities that a clinician has to face when sitting with his or her patient in front of them. And so what happens then is you get these missed opportunities, and our adult patients are not protected against vaccine-preventable diseases. And indeed, it is in the adult population that we see the greatest burden of mortality, morbidity, and cost to the healthcare system from vaccine-preventable diseases. We're actually, because of the work of our excellent pediatric providers, our pediatric population is actually very well immunized. It's the adults that we have the problem. But we think there is a solution, and it's a solution that's been around for several years now, which is why we have data that it works. The challenge is that they're not being implemented, and the solution obviously are standing orders. And what standing orders do is that it reduces those missed opportunities I just talked about, because what it does is that it takes that assessment and routinizes it along with the administration of the vaccine. And the way it routinizes it is by making it into a program, such that through a standing order, an individual physician no longer needs to meet individually with a patient to give an order for an individual dose of vaccine. So you can imagine I'm emphasizing that word individual because it's without the standing order, that physician has to meet with the patient, has to write an order for that vaccine dose, and has to do it every single time for every single patient. And so that's one of our biggest challenges, obviously, without the use of standing orders. The other thing also then is that once you routinize vaccination by making it a program rather than relying on that individual physician order, you can now empower other non-physician healthcare professionals in your practice to manage your vaccination programs. So, for example, you can take nurses and make them program managers for immunizations, or you can take some other legally qualified individual. And legally qualified is important because it does vary from state to state who can actually assess and administer under a standing order. And obviously, when you successfully do this through the standing order, the clinician time is now that he or she would have to spend individually every single time with a patient to give a vaccine is now freed up. And so that physician, that clinician, he or she is now able to do some of the more more complex, demanding chores such as managing obviously the chronic health conditions or the acute care situations in other patients as well. So I think these are the reasons why we believe so strongly that standing orders are obviously a huge solution to our problem with adult immunization coverage rates. And that being said, we're not the only ones that believe this. The next slide, actually, I'm going to tell you what a standing order is in the next slide, and then I'm going to actually show you some of the national policy guidance agencies out there that actually recommends the use of standing orders. So first, before I do that, let's talk quickly about what standing orders are so that we're all talking about the same thing. So standing orders really are simply written protocols, and again, they've been in existence for quite a while in medical practice, right? Where they are written protocols approved by a physician or some other authorized practitioner. And this, again, is a legal issue. It varies from state to state. Some states will allow, for example, an advanced nurse practitioner who has independent prescription authority to sign a standing order, and some states will not. But generally, it's a written protocol approved by a physician or some other authorized practitioner that then, once it's approved, authorizes nurses, pharmacists, or some other non-physician healthcare personnel, again, as allowed by state law, to basically assess that patient's need for vaccination and then give the vaccine without that clinician's individual direct involvement at that time of giving the vaccine. So if you can think about that, what that means is that all those problems that I talked about earlier, this idea that we're not assessing for vaccine and therefore we are not vaccinating, actually gets taken over by the standing order. And in the standing order process, it allows the assessment and giving of the vaccine in the absence of an individual physician interaction every single time. So that's the definition of a standing order and kind of the working definition that we're going to use going forward. So as I said earlier, we're not the only ones that believe in standing orders. There are a lot of national organizations of great creed who support the use of standing orders. So the Community Preventive Services Task Force, that is the United States, that's the equivalent of the United States Preventive Services Task Force, except instead of doing preventive services, they do community preventive services. They look at all the immunization literature. And when they did this, they did a study of they did a meta-analysis of 29 separate studies on standing orders. And based on that meta-analysis, they recommend the use of standing orders to increase coverage rates of vaccination among adults and children on the basis of a strong evidence of effectiveness. And in addition, the work that they did with this meta-analysis shows that it doesn't matter if the patient's in an outpatient setting or an inpatient setting. As long as you want to improve coverage rates in your immunizations, standing orders are strongly recommended by the Community Preventive Services Task Force. In addition, the Advisory Committee on Immunization Practices, or ACIP or ACIP as you might know it, they too recommend the use of standing orders for pneumococcal vaccinations as well as several other vaccines. So let's take a look at some of the nitty-gritty on standing orders and some of the numbers. The next slide I'm about to show you comes from a gentleman, Dr. Rick Zimmerman, who's out of the University of Pittsburgh Medical Center, and he is one of our gurus in terms of standing orders. He's been researching it and advocating for its use for a long time. And he did a study to take a look at how well standing orders are being used in physician practices. And what he showed is that with just adult influenza immunization, just influenza for adults, about 42% of physicians reported using standing orders in their practices. And that's not at all good. But then when he asked the question a little bit further and said, what about of those who are doing flu, how many of them are doing flu and pneumococcal vaccine, which makes sense because obviously a lot of times they're co-administered in the fall. The number actually dropped pretty dramatically to 23%. So only 1 in 4 physician practices were consistently using standing orders for both flu and pneumococcal vaccination. And so obviously Rick was interested in this, and he took another look to see. So of those that were successfully, the small 1 in 4, that were successfully, consistently doing standing orders, what were the factors that were associated with that success? Now, as I say this, I want to point out that on this slide, these are factors associated with success that Rick discovered, but they're not prerequisites. So as you go forward and you talk to your practices, right, and you encourage them to do standing orders to improve their adult rates, you don't need to have all of these things, but these are just some things that are associated with success. So what Rick found is that, of course, if a practice is aware that there are ACIP as well as Medicare regulations, and I'll show you the Medicare regulations in just a second, that recommend the use of standing orders, they are much more likely to obviously then, as a result, implement standing orders. And of course, as a practice, if the medical practice agrees that standing orders are effective, obviously that's also going to be a big factor in terms of implementing standing orders. And then finally, and again, this is, as I said earlier, no prerequisites here, but this is obviously something Rick found is an important factor that improves utilization of standing orders, is that if you have 2 or more clinical staff per physician, you have a much stronger likelihood that you're going to successfully sustain standing orders. And that's a lot of sense because there are obviously more clinical staff available to actually manage the immunization program and vaccinate a lot more people. And as I will say later on, the more people you vaccinate, obviously not only improving patient safety, but you're also probably improving the revenue flow into your practice as well. So therefore helping the sustenance of that standing order. But those are some of the factors that Rick found were associated with successful use of standing orders. So Rick then, of course, also then took a look and said, what are some other factors? But before I do that, let me go ahead and show you some of the regulations that I've been talking about or recommendations. So here's the ACIP recommendation for use of standing orders to vaccinate adults. And here is the CMS, or Center for Medicare and Medicaid Services, standing memo in 2002. So again, it's been out there for quite a while, authorizing the use of standing orders without the need for an individually signed physician order for folks like nursing home health agencies, hospitals, etc. So again, another big statement from CMS that using standing orders is something they recommend and suggest that this is used for their patient population. So again, lots of federal agencies, lots of high standing authorities advocating for the use of standing orders. So some other factors, again, just to kind of point out, again, none of these are prerequisites, but again, these are things that Rick has shown to be important in being able to use standing orders. One interesting factor he showed is that if you're a family physician, you're far more likely to be successfully implementing standing orders. And that's actually not that surprising if you think a little bit about it. And that's because if you think about family physicians actually vaccinate across the lifespan. So they do probably a lot of pediatric vaccinations. And as you know, in the pediatric practice, a lot of vaccinations are given under standing orders. I mean, the physician is not usually the person who's giving the vaccine. And so for the pediatric population, use of standing orders is actually something that's fairly common. And so for a family physician who vaccinates children, it's easy to see that they're going, hey, you know what, it's working pretty well for the kids. I'm going to try it for the adults. And of course, it works as we expected, all of us expected to, and therefore they have a much stronger incentive to keep them going. So family docs are a group of physicians that actually do a really good job with standing orders. This second point is something I'll touch on again near the end of my talk, and this is the idea of having an office staff that is very collaborative and actually very open to innovation. While standing orders are not necessarily difficult to implement, what it does require is actually coordination among all the office staff and buy-in. And that's something that we strongly recommend in our guidance that you'll hear about a little bit later on, is this getting the office team to buy in and to recognize and acknowledge the value of standing orders. Because when they go that way, I think then the implementation and sustenance of standing order programs work much better. Again, not a prerequisite, but obviously having an electronic medical record is very, very helpful. In fact, many practices now have electronic medical records where the standing orders are actually programmed into the electronic medical record. So when the patient's record comes up, the standing order also comes up and prompts the person looking at the record saying there's a standing order in place to vaccinate this patient with flu and pneumococcal vaccination, and then the person can go ahead and execute that standing order. So again, not a prerequisite, but it does make things a little bit easier. And then finally, this idea of the immunization champion, because standing orders not only require that whole team buy-in from the office staff, it does require that one person to be passionate and drive that engagement of the standing order into the practice and sustaining that engagement. So I think that immunization champion, again, none of these are prerequisites, but I think, again, this immunization champion is probably the one factor that I think is very positively associated with the implementation of standing orders and sustenance of those standing order programs. So some factors, again, that we think are important. Rick also, obviously, if you look at things that make things work, he also took a look at some of the barriers. I'm going to show this right up here. And obviously, this is a poll question. And I guess, Winnie, I need some help here. Do you want me to just read through these questions and then give people 15 seconds? So I'm going to read through these questions and give people some time to answer, and then I'm going to carry on. So the question is, what do you foresee as the biggest barrier in implementing standing orders? And after you pick your choices, we're going to come ahead and kind of talk a little bit about some of these. So weak or no organizational support, the small size of the clinical support staff, concerns about legal ramifications about malpractice, the patient's preference for actually having the provider manage the care, or frequently changing recommendations for vaccination. So I'm going to stop. Okay. So since I can advance the slide to the next one, I'm now going to actually give you the answers. So according to Rick Zimmerman's study, what he seemed to show is that there are several factors that are responsible for poor implementation of standing orders or barriers. And one of the big ones is weak or no organizational support. And this can exist both at the practice level as well as the system level. So let's think about the system level, for example. So let's say you're a physician running a practice and you're part of a system, and you come in, let's say you've attended one of our Take a Stand workshops, and you come back and you're ready to implement standing orders in your practice, and you need some policy support from your organizational, your system, like be it by through EMRs or something else, right? And you can imagine how hard it would be if the system's chief quality officer or the system's chief executive officer then tells the physician and the practice that, actually we're not going to support you because we don't think standing orders are valuable. So not having that organizational support is very challenging. And that organizational support exists also within a practice. If a nurse champion comes in and is ready to, hot to trot, ready to go with a standing order program, but the physician doesn't see any value in supporting that, that of course obviously makes the standing order that much harder to implement. And so that's one of the big challenges, is this idea of generating organizational support, both either within your practice that you're dealing with or within the systems that you might be dealing with. If you don't have a lot of clinical staff, and this is that flip side from the other point I said earlier, obviously it's a little bit more challenging to sustain the standing orders, because you do need that non-physician clinical staff to kind of implement the standing orders and give vaccines, assess the patients, and so on and so forth. And then the final one is this bullet at the bottom that we pulled out from Rick's study that was very interesting. And this concern about legal ramifications was specifically about malpractice. People were concerned, what if someone gives a vaccine under a standing order and there's an adverse reaction? Are they liable? Or if the vaccine was given inappropriately or incorrectly, are they liable? And so that's something else that we found in this. And so I'm going to take that one right off the table immediately. And the way I'm going to do that is by telling you that there is a program that protects against legal liability or malpractice as a result of vaccination, and that's obviously the Vaccine Injury Compensation Program. And so you can see here the data from another study from Rick that shows that the fear of malpractice is one of those big issues. And this is the slide on Vaccine Injury Compensation Program. Again, this program was established by the National Childhood Vaccine Injury Act in 1986. And specifically what it does is that it says that you are not allowed to sue a manufacturer, a provider of a vaccine, or a distributor of a vaccine because we now have this program that gives no-fault compensation for specific injuries that are temporally related to specified vaccines. So there's actually a vaccine injury compensation table, and on the table you'll see a list of vaccines, and then associated with each vaccine temporally will be some event. If that event happens temporally after that vaccine, there are no questions asked. The Vaccine Injury Compensation Program provides compensation to the person. If the specific injury or alleged injury is not on that table, then you still can't you can't sue the manufacturer or the provider for malpractice. You actually still have to take it to something called a vaccine court. And at the vaccine court, there are 3 special masters that sit on the court, and they will then adjudicate the decision as to whether that event that followed vaccination was truly as a result of the vaccine. And they would look at the evidence and so on and so forth and come to that decision. So you might have heard of this process most recently with the 3 special masters finding that vaccines do not cause autism as part of their vaccine court decision a few years ago. Because of this, the risk of litigation is almost none, and so we should take that fear off the table. And just a quick point to remind folks is that this covers all routinely recommended childhood vaccines. And therefore, as a result, if these childhood vaccines are given into adults, it's also covered for the adults. Consequently, there is one adult vaccine that is not given to children that is therefore not covered by the Vaccine Injury Compensation Program. And that vaccine, as you all might be thinking in your head right now, oh yes, I know what it is, you're all saying, it's Zostavax, right? Because Zoster vaccine is not given to kids and it's only given to adults. So I'm going to take that off the table. So that was one of the big concerns, barriers that we hear about standing orders. When we did our workshops and we trotted across the country, we actually did pre-workshop surveys to try to cater the workshops to the questions that people wanted answered. And the number one question, the number one challenge everyone told us for their standing order protocol and implementing a standing order protocol was that they didn't have a standing order protocol for the vaccines they wanted to use. They didn't have a protocol for influenza. They didn't have a protocol for pneumococcal vaccination. So what I'm going to do now is actually take that off the table as well. And I'm going to take that off the table by saying that the Immunization Action Coalition has standing order protocols for every single routinely recommended ACIP vaccine. Every single routinely recommended ACIP vaccine, IAC has a standing order protocol. And what I'm going to go through now in the next 10 minutes or so is I'm actually going to go through our protocols so that you can see what we consider to be the components of a standing order protocol that should be there. And as I say that, I'm saying should be there because obviously as you go forward, these protocols are for you all to use as you see fit. You can use them straight as is from IAC, or you can adapt them for your own purposes. And if you want to adapt them for your own purposes and you want to say, you know what, component number 5 is not really relevant for me, I want to take that out, feel free to do that. But in order for you to understand what these components are there for, I'm going to go through them one at a time so you have a sense of what we consider to be important components of a standing order protocol, and hopefully that will help you in either creating your own, mutating your own from ours, and so on and so forth. So here's a typical standing order protocol from IAC. This is for influenza, and I'm going to use influenza as the model for what I'm going to talk about when I talk about the different components of a standing order protocol. And as you can see here, this is something that we have, again, for every single ACIP routinely recommended vaccine. We have a standing order protocol for all of them. So what are the components that we think at IAC should be in a comprehensive standing order? And so we have, obviously, the next 2 slides will walk you through that. And I like to think of it as the journey of the vaccine, right? The journey of your patient through your vaccination operations, right? So what do you have to do? And this is kind of what the standing order protocol does. Because remember, you're basically taking, the person who's routinely, who's administering the vaccine under the standing order through the process of giving the vaccine and making sure he or she does not forget a step. So here's the journey. So the standing order protocol should have a component that says who is targeted to receive the vaccine. So this is the assessment, right? Who is in the patient population eligible to receive flu vaccine in this case. Then once you've identified the patients who can receive flu vaccine, the second component of your standing order protocol should look at that patient directly in front of you and say, can that vaccine be given to this patient? So now you're talking about contraindications, precautions, right? So if you've done that, the third component should then be the next logical step. You've identified your patient and you've said, yes, indeed, Mr. Jones can get his vaccine, flu vaccine. The next step then is that you should then give out any federally required information. And as many of you, and hopefully all of you know, the one piece that's federally mandated to be given out to the patient is the Vaccine Information Statement, or VIS. So you give that out. Once you give that out, now you need to start preparing as the person that's operating under the protocol, the standing order protocol. You now need to prepare the vaccine, and then you need to administer the vaccine. And so our protocol actually has 2 components that walk you through that. There's a component that talks about how you prepare the vaccine, and then we have a component that talks about making sure you administer it to the right patient, to the right route, right needle size, so on and so forth. And so we have 2 components that go through that. And if you go through both of those, obviously then you've successfully administered the vaccine to the patient. So the next part of the vaccine journey is to then document that vaccination. And our standing order protocol will have a component that documents, that advises the person administering the standing order protocol to document the vaccine in the patient record, and obviously as well in the state registries, and obviously as well in the and also we also recommend trying to give a patient record directly to the patient himself or herself, and I'll go through that a little bit. Then of course after documentation, should there have been an unfortunate rare event, there should be a protocol in your standing order protocol for the management for any medical emergencies that are related to the administration of the vaccine. And I'll show you a little more detail on that as well. And then after you've done that, obviously if you've had that unfortunate adverse event, you need to make sure you report that. And obviously many of you know that goes to a passive reporting system called VAERS. And then finally, at the bottom of your standing order protocol, after all these components are done, you have a box that is assigned by the physician that authorizes the standing order protocol so that people can now start using it. So these are the components of a standing order protocol that we think should be in it. I'm going to go through each one so you understand in a little bit more detail, not excruciating, but just a little more. And the reason for that is because then you can decide later on, if you're adapting the IAC protocol, you can decide whether you want to drop one of these components in your standing orders. So the first one, as we talked about, assessment, right? This is why the standing orders are so brilliant, because what they do is that they take that assessment component and routinizes it, puts it into the standing order. So in this case, we're talking about flu again as an example. And so who is targeted to receive flu vaccine? And as you can see, our protocol has a box, assess the adults for need of vaccination against influenza. And because of the ACIP recommendation, this one's easy. All adults are recommended to receive flu vaccination each year. And as the ACIP has stated, we put this in our little box, our component. People who do not recall whether they received flu vaccine this year should be vaccinated. And so that's our first assessment step. So now that the vaccine's been assessed, the next thing we need to think about then is that person now is sitting in front of you, you've pulled them out, you've assessed them. You need now to say, okay, can this person actually get flu vaccine? And this is our second component of our standing order protocol, and this is where you actually screen for contraindications and precautions. And as you can see here, we have a component in our standing orders that kind of lists in bullet forms the contraindications for all flu vaccines, for LAIV, and then at the very bottom for LAIV, and then at the very bottom for precautions as well. So again, this is the box that we have in our flu standing order protocol. You don't have to have this kind of complex information on your standing order protocol if you don't want to. You can basically say, refer to attachment on precautions for flu vaccine, right? So for example, you can then give them something like this. This is a screening checklist that helps the person administering the standing order protocol to check for contraindications against LAIV on the left and IE on the right. And so if you don't want to have that larger box inside your protocol, you don't have to. You can just say refer to and then make sure that they have the screening checklist in front of them. Okay, so now you've got a patient, you've assessed them, you've assessed that they don't have any contraindications or precautions. The next step in the journey obviously now is this idea that you've got to give them this, right? This is the federally required information. So this is the VIS. Got to give the VIS. VIS is given. I'm going to show an example of the VISs that you can get from IAC. So this is the flu VIS. The great news about IAC is that we also have VISs in multiple languages. In fact, we've got translations into over 30 different types of languages. So if you have a cultural sensitivity issue, please come check our websites. We probably have a VIS in the language that you need. This is the flu VIS that you can find at CDC. You can also find it at our website, and again, our translations are on our website as well. One thing I just want to point out here about the flu VIS, it is the first universal VIS the CDC has issued for flu. This was issued last year, and it's also good for this year, and CDC says it should be good for next year as well. So CDC has worked really, really hard at adapting the flu VISs so that we don't have to have a new VIS every single year. All of you are probably familiar with us all just waiting for when the flu VIS is going to get released. Not anymore. The flu VIS that you used last season is this one, and it's the same one that you're going to use this season. So just a little tidbit there about flu. Okay. So 3 components down. You've now given the federally required information. Now we actually have 2 components that are associated with vaccine administration and trying to reduce that error. So the next thing you now need to do is prepare to administer the vaccine. And in this case, it's checking that you've got the right vaccine, making sure that you've got the right route of administration in your head, and also the right needle size. And in our flu standing order protocol, you'll find that our component actually has a table that looks at the gender and weight of the patient, what needle gauge you should be using for that gender and weight, needle length, and then obviously the location for the injection. In this case, because it's flu vaccine, obviously it's the deltoid muscle of the arm. Okay, and then obviously we have a little blurb at the bottom. If you're doing flu mist, you need to prepare flu mist according to how flu mist is supposed to be prepared. And so this is the preparation component, getting ready to vaccinate. We then actually have another component that talks about, okay, now make sure you give the vaccine the right way. And so we actually have some vaccines. This is obviously for making sure that the vaccine gets to the right patient, the right vaccine, the right age group, the right dose, the right route, and the right site, right? Try saying those 6 rights quickly. But the point here, again, is that we're beginning to see an increase, an uptake in injuries related to poorly administered vaccine. In fact, the uptake is significant enough that the Vaccine Injury Compensation Program that we talked about earlier has actually added a compensatable injury class called SARVA, or SARVA. SARVA stands for shoulder injury related to vaccine administration. So enough shoulders are being injured because of poorly administered vaccines, wrong site, wrong route, that the compensation program has actually added that as a compensatable category. So that being said, that's why this box is here. And that being said also, we don't want people going out there just, willy-nilly vaccinating because it's compensatable. Obviously, our job is to make sure that vaccine administration is done accurately, appropriately, and effectively. And just to kind of give you a sense of how often these errors are happening, the fact that I can find pictures is not a good sign. I mean, a colleague of mine, obviously, and friend, Bill Atkinson, found a lot of these pictures, and then I asked him where. He said, you can find them. They're in the media. And so, for example, I'm sorry, I actually had some pictures that we took up in the interest of time here. But I've got some pictures that show vaccinations being done in the wrong site. And so I want to just point out again that it is incredibly important that we keep continuing to think about this because we don't want to see that continued uptick in shoulder injuries related to vaccination. Okay, so now that we've done that, we've administered the vaccines, and we've given them in hopefully the right place and the right site and the right route, and properly for flu vaccine. We now head to the next component of our standing order protocol, which is documentation, right? And this is extremely important. Once you've given the flu vaccine or whatever vaccine under standing order, you want to make sure you document the receipt of that vaccine in 3 places, we believe. First and foremost, obviously, the state immunization registry or immunization information system should be documented. And then secondly, the patient's medical record obviously should be documented. But as we know with regards to adult immunizations, our lifespan registries aren't there yet. They're not fully populated with data, and we know that EMRs are not yet talking to the registries. Now, hopefully all that will change in the near future with meaningful use and the implementation of MACRA, but as we go forward, we know that's not there yet at this time, and so IAC also believes that you should give the patient their own personal immunization record card. This is an example of what one could look like. We have these on our website for sale. Today we've sold more than 10 million copies of these. They're virtually indestructible. If you write on good black ballpoint pen, you can throw the whole card inside the washing machine and it comes back out and you can still see all the vaccines that you received. So until our immunization systems, information systems align with our EMRs, we think it's a good idea to give a patient record back directly to the patient as well. Okay, so now you've documented the vaccine, and what's the next step? Well, heaven forbid you have some event following the administration of the vaccine. So you should have a protocol in your standing order that talks about how do you manage those medical emergencies. We have a box here that says be prepared. If you're giving a vaccine, you've got to prepare. It's rare, but it can happen. And what we do is we actually then refer people to this checklist of medical management of vaccine reactions in adults. And so something to guide the person administering the vaccine through the standing order on what to do and what are the different medical management strategies that are out there for potential vaccine adverse reactions. And of course, if you did have a vaccine adverse reaction, following management of that adverse reaction, you should, of course, report it. And it is reported into VAERS, which is the Vaccine Adverse Event Reporting System. I just want to remind everybody this is run by CDC and FDA, and it is a passive system. In other words, anybody can report an adverse event temporally related to vaccination to this system. It does not distinguish causality. It does not say that one caused the other, vaccination caused the event. All it does is generate a database from which hypothesis can be tested. So it's a signal generator. So just kind of keep that in mind about the VAERS. Here is the website for VAERS. And as you can see, this is a pretty simple website to report any potential vaccination adverse events to VAERS. Okay, so now you're done, right? You've done the vaccination journey. You've documented vaccines. If there's an adverse event, you've told them how to handle it. The last thing at the bottom of your standing orders should be this box. This box says that the procedure shall remain in effect until a rescission date. We recommend putting in a rescission date because it is important that as ACIP recommendations change, you actually come back and take a look at your standing orders and make sure that it's still doing the right thing per the new ACIP recommendations. And we also believe that when you have a rescission date, it also makes you come back and revisit this whole idea of immunizations. With flu, for example, we think it's a great idea because if you do it every year, and as Bill Atkinson likes to say, when your first dose of vaccines come into your practice, that first box of vaccines should be given to you and your staff. And then you should perhaps take opportunity to use yourself to give to each other, and at that point in time, practice and make sure that you're all still competent in your vaccine administration skills, right? So by doing this, it gives you a chance to kind of go through some of these things and think about it a little bit. So I'm going to spend the last few minutes of my time and talk about the data that supports the use of standing orders. I think a lot of you have probably seen this, but I'm just going to go through this again. This is the Community Preventive Services Task Force, and that's that study of the 29 study. That's the meta-analysis of the 29 studies I talked about earlier. If you take a look at this, just by using standing orders alone, nothing else, they found that it increased adult vaccination coverage rates by 17 percentage points. However, when you use standing orders in combination with other interventions, and this is fundamental. If you throw it in with things such as improving access to the vaccines, or throwing it in with reminder recall or patient education, provider reminder recall, it actually it increases the adult immunization coverage rates in the practice by a median of 31 percentage points. So this is an analysis of 29 studies. The same studies also showed that these standing orders could increase vaccination rates in a range of clinical settings and a range of provider and patient populations. I highlighted the inpatient and outpatient settings early on in this presentation. And of course, with the patient population, you can use standing orders for vaccine delivery to children as well as to adults. And this is the United States Community Preventive Services Task Force finding. Other data, I'm going to show you some data from a study that was done with 4 practices. 2 practices implemented standing orders for influenza and 2 practices did not. And I think without looking at the legend, you can tell which were the 2 practices that implemented the standing orders. It's a whole 27 percentage points better than the practice that did not implement, the 2 practices that did not implement standing orders. And so you can say to me, LJ, well, that's flu, and that's a long time ago. What are something more recent? And I'll just pick this one out. This is data that was presented in 2015 for the NFID's Clinical Vaccinology course by Alison Kempe. And Alison basically took a look at a large health system in Denver called Denver Health, who were very dissatisfied with the adolescent immunization coverage rates. And what they decided to do was implement standing orders for these adolescent vaccines that you see on the left side of this table. And then what I want to do is draw you all the way to the right and take a look at the Denver Health numbers. Those numbers are impressive. If you think of Tdap, 95.9% coverage rates. Compare that to the national coverage rates of 86. Look at the MCV4, 93.5. Look at HPV females, 90% almost. 66% for 3 doses or more. Compare that with 37.6% as the national average for 3 doses or more. If you take a look at these numbers, you take a look at them and look at them over and over again, there is no doubt in my mind that standing orders work. They are effective at increasing immunization coverage rates. And what about for the physician practices that you have to go and talk to and recruit? I can tell you that if you take a look at the physician practices, I can push every lever that a physician practice might be interested in. So for example, if you're interested in for example, efficiency, as we talked about earlier on, when you take away that need to meet with every patient, that individual assessment, and move it into a routinized program, you improve clinic efficiency. And then more importantly, you save that practitioner's, that physician's time or that clinician's time for handling some of the more complicated situations for which they definitely are needed to be considered for their patient. So I think it improves practice efficiency greatly. And obviously, as nurses take charge of that vaccination program, you see more patients. With more patients, you also see improved income stream. But if you're not interested in revenue stream, if you're not interested in practice efficiency, one of the big things I can tell you about, and I hope this is the reason why standing orders are implemented, is because of patient safety. We think that there's a huge reason to implement standing orders because you improve vaccination coverage rates. It's a huge quality gap. You will reduce vaccine preventable disease, and as a result, also obviously reduce opportunities for vaccine preventable disease transmission. All great things that you want to try to achieve. So here are the summaries of some of the things I've just told you. The one thing I want to point out here is that we know standing orders are really endorsed and they're supported by data, but we know it's not being done. And I think we hopefully have showed you some of the ways that we can go ahead and implement these standing orders, which is what I'm going to go to in the next slide. The one thing I'm going to point out here, which I'll talk about in just a few more minutes, is this idea that it's not difficult to implement standing orders, but you do need everybody in the practice to buy into this. And you do need that immunization champion to be pushing this in order to sustain it. So IAC has created a new product to help this very difficult part. How do you implement standing orders in a system or a practice? And we thought that, we created what we call a cookbook or a guidance. It's a 6-page guidance, and I'm not going to go through all of this because this 6-page guidance is brand new. It's now available on the IAC website. It was just released this year. You can find it on the IAC website at this link you see on the slide. And I'm not going to go through this because this actually is the subject of a 4-hour workshop that we do at our Take a Stand to help people kind of figure out how to implement standing orders successfully in their practice. But we do have 10 steps here. I'm going to spend just a few more minutes before I wrap up to go through those 10 steps so you can see what the content of this document is so that you can go and take a look at it for yourself. So here are the 10 steps that we go through in great detail in our guidance and in our workshops. You want to, very first and foremost, again, here's that organizational support. You want to discuss the benefits of standing orders with the leadership. And one of the best ways to bring them on board is to actually go ahead and audit your rates. People always think they're doing better than they really are. And the moment you find out that there's a quality gap in your adult immunization coverage rates, they tend to then take action. And this is a great way to get the buy-in from the organizational leadership that you need to do something. Once you've got that buy-in and you're ready to move forward, we think that identifying the immunization champion, and it doesn't have to be the same person, but someone who's passionate will take charge and say, I'm going to make this happen, and take that standing orders program and move it into the practice. And this person working with the leadership should decide, what vaccine are we going to do? Do you want to do just flu? Do you want to do flu pneumo? Do you want to do all the big 5 adult vaccines? But there should be a decision that's an agreement with leaderships and their goals for what vaccines that you're going to use. And once you do that, you then develop the standing order protocol. And I will say again, take it off the table. You don't have to develop them. You can just take ours. We have them for every single ACIP routinely recommended vaccine, or you can take ours and adapt them. Either one's fine with us, but you don't have to create those standing order protocols. So now you've got buy-in at the leadership level. You've identified your vaccines. You've got your protocols ready to go. Here's that staff meeting. Here's that point where you take everybody in your practice staff and you bring them all together and you talk to them and you make sure that you've got all of their buy-ins and address their concerns, right? So this is that staff meeting where you're going to tell them how you're going to implement standing orders. And we actually created a talking points card. There's a card with several talking points that we've created for you to use when you hold this team meeting and talk to them about why you're implementing standing orders in the practice. At this team meeting, I think you can also do 6 and 7, because I think it's a great way to, again, get buy-in. You should address the concerns of these of the staff members at the same time as you discuss the roles that they're going to play inside your standing order protocol. So, for example, I believe it's highly unlikely, and standing orders are not meant to cover 100% of your patients. There will be patients that will fall out of the standing order process because they ask a difficult question or because they have some strange rare medical condition that they asked you about that requires a little more investigation. And so at this point in the staff meeting, you should decide, what are your trigger points for pulling a patient out of the standing order protocol? And then if that happens, who's the next person? What's the role of the next person? I mean, is it a nurse or an NP who will then take that patient and work that patient through the process, find out what the concerns are? I mean, so those are the roles and processes that should be kind of decided. And when I talk about processes, this is number 7, the operational strategy. Who comes in? Who checks in? Who checks in the patient? Who looks at the standing order in the EMR, and so on and so forth. Those kinds of studies have to be looked at. And again, doing this in a team allows you all to address each other's concerns. So for example, let's say you've assigned the role to an MA to give a vaccine, and the MA says, I'm really not comfortable talking about vaccine hesitancy. You can now say at this point in time, let's train everybody and address your number one fear so that you're now more confident going forward and you can perform at the top of your degree and license, right? So there are things you can do to really get the buy-in through this team meeting. And then once you're done with this, you're ready to go. You want to make sure your patients are obviously getting vaccinated under the protocol. And one of the things I tell people is put a sign up. Let people know you're vaccinating. And more importantly, think innovatively, right? Tell them, you now have standing orders. And if you're under standing orders, you can now hold immunization-only clinics where all you need is the nurse. And therefore, you're now holding after-hours flu vaccination clinics. Think like the pharmacists. They've done this really, really well. And so the practices should also do this as well. And then obviously you start vaccinating, and then I tell people you need to review your progress because you want to make sure that you're doing better, right? If those coverage rates are going up, I can bet you're going to get organizational support to keep going on these standing orders. So here are our top 10 list. Want to just end by telling everybody again that standing order protocols, you don't have to do them on your own. This is our website. All our clinic resources for standing order protocols are there. Please take a look. You don't have to create your own. And then for more resources, a lot of the talking point cards I talked about, the Take a Stand guide, you can come to any of these resources on our website and you will be able to find them. So I took a little bit longer than I thought, but I have about 8 minutes left for questions. Is that okay if we take questions now? And thank you for your time. Thank you for your attention and for the opportunity to talk to you about something I obviously cared very deeply about. So thank you. Oh, sorry. Let me read this. I forget there was a poll question. I apologize. And so I know I went through a lot of information, and I know you're going to process this, but I hope I conveyed to you the importance of standing orders. So I'm going to read this question. How likely are you to implement standing orders? And I know some of you are not necessarily going to be clinic practices. Some of you may be in other positions. But just give us a sense of whether extremely likely, unlikely, neutral, likely, or extremely likely. And if you're already implementing standing orders, if you can, that's something that you should just click here and say that, you're already doing it, so you're extremely likely to be doing standing orders because you're already doing it. And I hope that in those cases that what I've told you today will actually help you continue to sustain those standing orders. I'm going to just let you have some time to click on your answer responses. And then I'm going to turn it back, and then let's take some questions.
Thank you, Dr. Tan. I have a few questions from the group. One is standing orders have been pulled in our healthcare system because of interpretation of rules from the Joint Commission. We can do something called nurse-driven protocols. Is there a difference? Are you aware of regulatory concerns with standing orders?
So that's a great question. So I think, as you know, the Joint Commission is a national body, and so I don't know specifically which control standards you might be talking about, but it would depend on your state. And I think one of the things that we have to kind of distinguish with state authority is who gets to firstly obviously assess, who gets to then prescribe the vaccine dose, and who gets to administer the vaccine dose. And the standing order protocol can recognize that all three processes of that, depending on who the healthcare professional is. So in some states, for example, MAs are allowed to administer vaccine under a standing order, but they're not allowed to assess. And so those are things that we have to work out on a state-to-state level. But that being said, I think standing order protocols, I don't think you should have pulled them. I think you should take a look, obviously, and we can help with this. These are some of the things we've done before as part of our workshop. We can take a look at the legislation that's driving some of your concerns, and in many cases, it turns out that it's an internal policy and not actually a state legislation or regulation. It turns out that the system is worried or conservative in interpreting a law or a regulation and has put in internal policy that's actually simply that, and that perhaps by working with a champion or by working with someone who's passionate about the cause, that internal policy can actually be changed. So this would require a little bit more of an in-depth examination of the question, but those are some of the broad things that we've encountered in our workshops. I know it's not the perfect answer, but I hope it's an answer.
Thank you, Dr. Tan. Another question is the weak organizational support due to the concern of legal ramifications?
Yeah, that tends to be, especially in the systems, right? A lot of systems are concerned about, again, the medical ramifications, and some of them are also concerned about the legal ramifications I just talked about. And so, the idea that they're worried that a person is vaccinating and that the state does not allow to vaccinate. So we actually go through a lot of this in our workshop. It's very state specific, and we go through a lot of this in our workshop to figure out exactly what the ramifications are in the specific state that we're in. But that being said, I will tell you that the medical liability ramification is something we hammer home, and I think we're beginning to take that off the table for a lot of the leadership. I think for the leadership, a lot of them just simply need to see the data. What we've been told is that when leadership sees the quality gap, they want to do something, and when they find out that it's a standing order that doesn't actually change costs ramifications in terms of operationalizing it, they become very eager to try to do that. And we're working with several systems right now across the country to try to figure out, how to get standing orders implemented in their systems because their leadership is beginning to buy on. So, and one of the things I tell people, I can use standing orders to push every single leadership button. If you've got a quality officer that's resistant, I can talk to them on quality issues. If you've got a financial officer, I can talk about fiscal return. If you've got a medical officer, I can talk about patient safety because standing orders addresses all those concerns.
We have time for one more question. It is, we have a screening tool for influenza. If that patient meets criteria and qualifies to receive the vaccine, the medication automatically drops to the medication administration record, or the MAR, to be given. Does this qualify as a type of standing order?
Yes, it is. That's the system that I was kind of talking about earlier on, where you've got an electronic medical record that's now programmed with the standing order. And what happens that when the evaluation or assessment of the patient happens because of the electronic medical record, the standing order then pops up and says, hey, look, you've already got a prescription for the drug because of the fact that it's on a standing order, and the EMR automatically populates it into the medication list for the patient. So that's a beautiful example of how when you automate the standing order with the electronic medical record, you can really improve immunization rates. Thank you for sharing that example. Yes, it is. Thank you.
Thank you, Dr. Tan, for volunteering to present on standing orders, which really can make a difference in our adult immunization rates.
Just to point out, I think Robin's also on the call. You can give us some email if you have further questions, but also we're intending to come to Nevada to do a mini standing order workshop. So we'll, if you want to keep in touch with us, we can. There might be an opportunity for practices to come take our workshop.
And Dr. Tan, this is Rini. We can help you get information out on that.
Perfect. It's not going to be our traditional 4-hour workshop. It's going to be an annotated, innovative version of that. But I think a lot of that training will come through still.
Great. Once we end this presentation, please complete the post-webinar evaluation. It'll pop up when you end the connection. Thank you for attending. Take care.
And thank you again, everybody, for your attention. Appreciate all the work you do.